All right. Hi, everyone. I'm Lindsay Wade with the Hospital Association of San Diego and Imperial Counties. And I'm going to go ahead and have my colleague Stephanie introduce herself.
Hi, everyone. Stephanie Fan, also with the Hospital Association of San Diego and Imperial Counties. And I'll pass it over to Erica.
Absolutely. Hello, Dr. Coleman, and hello, everyone else who I've yet to meet tonight. It's a pleasure to be here. I'm the Community Benefit Manager at Sharp Healthcare.
Lindsay, are you able to share your slides?
Yep.
Okay.
Yep. So let me start with a few caveats, my favorite things. So you are one of the very lucky early receivers of a presentation on the 2022 Community Health Needs Assessment. And so as a team, we're still kind of figuring out the best way to describe everything that we learned from the community throughout our process. Both Steph and I, at least for us, are really comfortable being interrupted and really like an engaged conversation. So we're gonna share some information, but like for us, it's really about hearing the conversation and getting to what we do. So we're gonna give you some background, but are really excited to kind of get to the next part. So with that, I'll kind of get started. Oh, who here has ever heard of a community health needs assessment? We got 2, 3. Okay. Thank you. All right, so there's some general familiarity. So I'm going to go ahead and share my screen. We have been facilitating a collaborative community health needs assessment here at the Hospital Association for a long time. In the mid-90s, there was a requirement that not-for-profit hospitals do research to understand what the most important health needs are in vulnerable at-risk communities. But we've taken a much more collaborative approach in San Diego, where we've all worked together so that not each individual hospital and health system was like going to the same people and asking questions over and over, and that we kind of come up with a shared report and a shared kind of vision for what the top needs are in the community, instead of it just being hospital by hospital or health system. And the big evolution this time for our community health needs assessment that really was the result of the collaboration between hospitals and health systems during the pandemic is that every single hospital and health system in San Diego now participates in the needs assessment. At least all the private hospital health systems, County Psych Hospital was a participant, our freestanding psych hospitals, even on our investor-owned hospitals. And we don't know of another place in the country that has kind of had such a broad engagement beyond those hospitals that have a regulatory requirement to do a community health needs assessment. And our board of directors does include the administrator from the Naval Medical Center. And so she's aware of the findings as well, but we haven't been able to figure out how to have Navy as an official participant, but are open to advice on that. But we did get the VA to participate, so we're working that way. Does anybody have any questions before I kind of just start? So I'm going to ask Stephanie to take over and do a very quick overview of the way that we conduct the assessment, and then we'll move to the findings.
Great, thanks, Lindsay. So here in this graphic, you'll see our overall methodology and approach to our community health needs assessment. So we use both quantitative and qualitative data collection methods as part of our process to help us identify and prioritize the top needs in our community. So on the right of the graphic, you'll see the quantitative data, so the secondary data sources that we use from entities such as CDC, hospitalization data, and of course, some of the data that's made available from our county community health statistics unit. And then on the left-hand side of the graphic, you'll see more of the qualitative data that we collect. So that primary data, right? So things like key informant interviews, focus groups, and then also data we collected through a online community survey, and then also kind of new to this process, an access to healthcare interviews, I'm sorry, that were conducted by community health workers and also promotoras. And then kind of in the middle, anchoring both our quantitative and qualitative data, was our health equity framework, which I'll go ahead and speak to a little bit briefly in the next slide. And I'll pause right there in case anyone has any questions.
Stephanie, I'm just
Yeah.
curious, like from the graphic before, how much was this informed by the previous needs assessment?
Ooh, great question. So we actually build and use our previous needs assessment to inform our next process. And Lindsay, if you wanted to add anything to that. Yeah, I would say it's a continuous cycle of we're always continually building on things from the previous assessment. So for example, for the 2019 assessment, we would use 2016. For the 2019's assessment, we'd use 2016's assessment. And then for this current 2022 year, we would use findings and other things in our processes from 2019 to inform.
Thank you.
If that makes any sense. All right. Great. And then talking a little bit about our health equity framework here. This was foundational to our collaborative CHNA work this cycle. And this was just how we were going to approach our research. And this was based on best national practices and evidence-based frameworks from resources such as the CDC and also the American Hospital Association. So the following principles you see here are laid out, they're pretty straightforward. These are principles and values that were adopted by our CHNA committee, and they would be ultimately just how we would approach our research, the community, our community members, and our partners. But I think what's important here to highlight are two principles, and they were absolutely critical for us to master, especially for this CHNA cycle for 2022. And that was inclusion and empathy. And this was in light of all the civic discourse and conversations, right, that were happening around the height of the pandemic and directly afterward. I mean, we're still experiencing them, right? So the first one I wanted to highlight was inclusion, and that was just understanding the importance of sharing a space for listening, honoring perspectives, and including voices of those with lived experiences. So we ensured for our CHNA that community voices were represented and present. Also with the principle of empathy, just creating that safe and meaningful opportunity for us to engage with community members and community partners in a trauma-informed way. So for example, with our community partners, we had to adopt a trauma-informed approach because we knew just how tired and broken and exhausted everyone was from serving the community, how there was just so much uncertainty going on. And, we made sure to make it known that we were just really, really appreciative of how they were able to make time to sit and reflect and, just let us know what they were seeing in real time through their observations. And then I'll pause there in case there's any questions. Excellent. Thanks, Lindsay. And, all in all, we had 841 participants, and related to our work or commitment to inclusion, I should say, I wanted to kind of highlight the survey that was done in 6 different languages, including English, which is just reflective of us wanting to communicate and incorporate more best practices, right? Because we know that people who speak different languages often feel more comfortable reading and writing in it and also responding in it in a survey, for example. So all in all these efforts, those focus groups, those key informant interviews, the survey responses, and those CHW and promotora interviews that led to just our view of everything that was going on in the community. And I'll go ahead and pause there. If there's any questions?
Stephanie, this is related to the last slide. I'm sorry, I was slow in unmuting myself, but what does the accountability aspect of the needs assessment entail?
Lindsay, did you want to go?
You go ahead, we can both do it. This is like a big deal for us, so.
Yeah.
Go ahead, sorry.
Just making sure that after, after we complete our assessment, that we're going back to the community and making sure that we're keeping them informed of how findings will be addressed with everyone that participated. So having that personal accountability towards our partners, community members, and those who participated. And then Lindsay?
Yeah, just making sure that they understand that their feedback was heard, and we like to kind of share, like the CEOs of all the major health systems in particular heard directly, right? Some of the things that they shared and how hospitals are working to address that. And then to the extent that we can, which is pretty great, like making sure that we're able to get them whatever data from the report they can use for their own purposes. So if there's anything that we can break down further or share back with any of our community partners, we try to do that. Even before the report was released, we started kind of like feeding certain things to our community partners who are working on grants, because it's what it's supposed to be about, is about kind of being a support. But it's we want to make sure that the research doesn't just stay with us, is that we work to get it back out to all the people who generously share their time.
Thank you.
I'll just go kind of into a deeper spot quickly on our community engagement and just say, as a team at the Hospital Association, not only did we like broaden our participation, but we brought this process internal to us for the first time, so that we didn't have a contracted entity who was doing interviews. It was our own team that was kind of taking on focus groups and interviews and designing the survey and all those pieces. And to do that in the midst of a pandemic, we all felt more disconnected than we ever had from the community. And we're looking for some good solutions to really try to address that, even though it wasn't like a great time to be holding public events or like in-person conversation, which is mostly how we had done this in the past. And so one of the strategies that we came up with was to leverage our partnerships and relationships with organizations who have community health workers and promotoras. And so just wanted to highlight that piece. We worked with the San Diego Refugees Community, the Refugee Communities Coalition, and the Chicano Federation, and they conducted 223 interviews with community members to kind of dig deeper into access to healthcare challenges. And those interviews were conducted in 23 different languages. So that brought a lot of information for us that would have otherwise been a big gap. And then we also partnered with the Institute for Public Health, and they held focus groups with the community health workers and promotors that were part of the county's Communities Fighting COVID initiative. And so these were frontline staff, promotors, who would be the first person that could help someone with a COVID diagnosis try to figure out how to navigate systems, how to try to isolate safely or get healthcare or take care of whatever was going on with their family. And so it was great to have that trusted partner with the IPH and be able to tap into Communities Fighting COVID, which is a nationally recognized best practice during the pandemic. But it was a really hard community engagement, very different than anything we've done before, because of how exhausted and traumatized everybody was that we talked to, and how separated we felt from the community because of how things were at that point with the pandemic. Amy.
That logo, the Federation, what was that about?
Chicano Federation.
Oh, wow, that's excellent. Right, and the Institute of Public Health, is that affiliated with one of the universities?
Yes, I'm so sorry. I'm looking at this slide and being like, what? Nobody knows these words. I need to fix this.
It's okay.
The Institute for Public Health is kind of like the public health practice arm of San Diego State University's Graduate School of Public Health.
Excellent.
And we worked with them for a long, long time. and I'm sure we'll continue to rely on partnerships with them going forward.
Great. Thank you.
Okay, so I'm gonna go into the findings. Our board of directors, like our hospital CEOs, found it interesting to kind of watch the progression of how we've evolved in our needs assessments over time in terms of how we incorporate social determinants of health. In our 2016 report, we've still had this primary focus on health conditions and diseases, and then like a separate list of social determinants of health. And then by 2019, we at least had like everything together, but we still were separating social determinants from health conditions. And then this time was a big jump in evolution in terms of really taking what we had learned from talking to the community all the time, that for the most part, anytime we're asking about challenges in higher need areas, they're telling us about social drivers and social needs and barriers to improving health, and not as specifically about specific health conditions, with the exception of behavioral health, which is always kind of top of mind in any conversation. So it was a big evolution to abandon like what was the hospital comfort zone, really focused on just talking about chronic health conditions. So moving from, right, like in 2016, the focus on cardiovascular disease and diabetes, and heading over to the more of the drivers of health. So as we kind of have already been describing, it was a really different process and conversation that we had this time around. In 2019, we were already beginning to come to grips with our understandings of how much impact stigma had on people's ability to access services and manage their health. We were starting to learn more about trauma, but in our conversations for this needs assessment, it was just a key underlying theme throughout every single interview and focus group. And so you see in the findings that we did something different. We had foundational challenges, which are represented in blue, and then underlying themes of stigma and trauma that are on the side in orange. And again, in every single conversation, we wanted to call this out as something different we hadn't done in needs assessments, that this impacted absolutely every need that was identified. Health disparities, of course, were always a problem, but the pandemic really amplified and made things worse. And then workforce, oh my gosh, right? Not a surprise to anybody, but the part that was scary for us as interviewers is how pervasive the concerns were across the spectrum. So we're talking with people in early childcare, and we're talking with people in skilled nursing, and there's basically an incredibly huge concern around workforce, to the degree that, you know, we couldn't even get to solutions-based conversations for the most part, because I think in previous years it'd be more about funding, right? If we had funding, this is what we could do. And in this time, we would be talking, like it stands out for me with a home service provider, and they got a grant, but it doesn't matter because they can't find any staff. So it's just a really intense part of the conversation. And I also feel like really associated with the underlying themes, especially trauma, because so much about what we were hearing was just like the shared trauma of the workforce as they were trying to serve their patients and clients during the pandemic, and how incredibly hard that was in terms of what everybody was going through. So that was, it's kind of the summary of the overall findings in terms of like the key underlying themes. And then the needs, the top needs are identified in the middle. And this graphic kind of helps lay them out with a little bit more detail, because a lot gets kind of lumped into each of the top findings as we describe them. So access to care, aging care and support, behavioral health, children and youth well-being was a new addition for us this time with a needs assessment. I think in previous assessments, we had worked to address children, but it was almost always like an afterthought. We would talk about a concern, and then there'd be like this other piece about children. And we really wanted to center all of the concerns we were hearing about children in one place, especially since with the pandemic, the concerns around children's mental health were really escalating. and all kinds of other things which are captured in there. Chronic health conditions, community safety, and economic stability. One thing that was different about the way that we framed the findings is that instead of identifying things that we might have had as a social driver before or as a top need like homelessness, we instead took homelessness as like a population of focus, and it was more of a cross-cutting issue. Instead of calling out homelessness as the problem, the focus for us in the report was more describing the experiences of people who are experiencing homelessness in terms of access to care, in terms of aging care and support. Across all the findings, you can see the perspective and challenges that are specific to people experiencing homelessness. And we had that same approach with other cross-cutting issues and populations, including human trafficking, LGBTQ health, and we made an attempt around veterans and military connected families. That's been a real deficit for us in the needs assessment before, and we're still not where we need to be for, you know, like a military town, but we're working to get better. So I'll stop because the slide is super overwhelming, but this is like the summary of all the work basically.
So I just want to clarify, when you say trauma, you're talking about psychological trauma?
I think we mean psychological trauma, but that could also be from the result of physical trauma, based on kind of our understanding of the way that it was described for different populations. But mostly it was about trauma from experiences and vicarious trauma, generational trauma, historical trauma. And we try to get much better at bringing some resources into the report. We can talk a little bit more about that. So for trafficking, just again, as a team, this is something that we had not included in any previous needs assessment. And I think it was a lack of understanding and awareness, at least on our part. So I've been working with Amy and this committee for a while to get better educated. Oh, I see a question. I'm sorry, Sharon, go ahead.
No, it's okay. When you guys did this this needs assessment, did you guys actually speak? Is it the population that you guys use? Is it just the let's just say patients or the general public, or did you guys also did you guys also interview healthcare workers?
Oh, that's a great question. Sorry, thank you. We did all of it, I think, everything that you said. So we did have focus groups that included patients. Part of us expanding the needs assessment to every hospital and health system was because we recognize that the keepers of a lot of that information about our most vulnerable community members are at the hospital, right? So that patient that can't get discharged to a skilled nursing facility, the behavioral health concerns that we see in our emergency departments, just a lot of those issues, the expertise is within our own hospitals and health systems. And so we did do a lot of interviews with case managers, psychiatrists, behavioral health leads, behavioral health directors, ED directors at hospitals, and we had never done that before. So we brought in some different things that might not have been included otherwise, but feel really important to kind of understanding the full spectrum of challenges. But we had key informant interviews with kind of nonprofit community leaders, just like a huge range of different people.
Thank you.
Yeah, no problem. So I don't want to dig too much into all of the findings, but like a few of the places where we saw human trafficking explicitly mentioned, and we included that in our report, with access to healthcare, economic stability, and children and youth well-being. And around access to healthcare, again, this was us trying to bring in the voice of community members in terms of their desire to have care that is much more welcoming and trauma informed, in order to meet the needs of patients, around economic stability. We called out the increased risk for trafficking because of how much economic pressure people were facing. I think with our report, this is going to be the first time a lot of our audience kind of is introduced to the topic. And so we were trying to include the opportunity to learn about it in lots of different spaces within the report. I'll be really curious to see how we did on that. And then I think it was surprising to us in terms of our conversations with healthcare providers when we did interview the ED staff at Rady, without prompting, brought up their concerns about CSEC and what they're seeing at the hospital. So all that's reflected there in the report. Okay, questions?
For those of you who don't know what CSEC is, it's commercial sexual exploitation of children. And it's great that Lindsay and Stephanie are familiar with that acronym already. And it's wonderful to have this framed as a public health issue, because it is. And that it's done at the same time that we see so much psychological trauma with healthcare workers. And we really need trauma-informed care, not just for the patients to facilitate the best outcomes, but for the clinical staff, because it will support their psychological safety as well. So I thank you so much for all of this work. I know how hard it was putting it together.
Yeah, we are learning. And so we can share a slide deck, and I put the link to the report, but like across all of our findings, like we just showed, we did try to bring in trauma-informed care, especially within access to healthcare, and economic stability. Again, all of these pieces are here, making sure that people understand that connection with trafficking, that I don't think is obvious otherwise without a little bit of help and education. And then in community safety, I just wanted to highlight, this was a really different take on community safety. So we did include kind of a focus on what makes people safe and populations who are at risk for being unsafe. So human trafficking, domestic violence, specifically calling out the safety concerns of people experiencing homelessness and how that impacts decision-making. And then also, again, I think unusually describing hospital workforce safety, because that has been an increasing concern. And we feel like it's an important issue for the whole community when nurses and doctors are under such constant threat of violence. So that is kind of like the summary. We did pull in, just for this group, some of the key themes around human trafficking that stood out for us as we were learning, and that we wanted to have highlighted in the report for other people as they're looking to address things. So we had mislabeling as non-compliant, just to be able to educate within our own hospitals and health systems. Again, multiple times, lots of times, calling out the need for trauma-informed care and support. And then we also, and within the findings, describe kind of the top gaps for survivors of human trafficking that we heard through our interviews. I think I can kind of stop there and see if there's more questions.
I have kind of a comment, and like this came up a lot, but not just locally, but also like at a conference I was at this weekend, where in a medical setting, trauma typically means physical trauma. And so there's a lot of pushback using that terminology. And so we've just kind of discussed reframing it as psychological safety so that stakeholders see it for what it is, because even though trauma-informed care has been around for decades and decades, it still hasn't quite saturated the culture. And so, but if we say psychological safety, that frames it in a way that everybody's on the same page. So especially when you're talking to the stakeholders in your systems about updating procedures and things to support all of the stakeholders involved, maybe using that language, at least in like as we start to introduce these topics, might be the most productive way to approach it. And then I did put in the chat for everybody, Sharp's continuing education series that we worked on trauma-informed care. It does include the PAIR tool, and the PAIR tool is a trauma-informed and evidence-based instrument that supports people that are in unsafe relationships. So that's human trafficking or domestic violence or any other type of thing that's related to those. Sorry. Didn't mean to go off on a tangent, but other comments, questions? Sharon, do you have your hand up still? Did you have a question?
Sorry, my fault. No, I don't have any more questions.
Okay. So I really appreciate that this supports grant writing that we need to address some of these gaps that can be frustrating for all of the stakeholders. So we appreciate your work.
Yeah, thank you. I'll put the link to the report in the chat again. I know we have a lot more work to do, and I hope that we can continue partnering with this committee to learn and share and bring back best practices to all of our member hospitals.
Absolutely. Erica, do you want to kind of give us some background on how our healthcare systems support the needs assessment to address these gaps?
Sure, absolutely. And I think, first of all, awesome to see one of the first community presentations on the needs assessment. I know these two, among others, have been working really hard. And so I'm happy to be able to address a little bit of the accountability piece with some of my information, but I'm going to go ahead and share my screen and talk a little bit about how Sharp in particular takes results from the community health needs assessment and integrates into our community benefit program. So one moment, please. All right. Oops. You guys see my full screen?
Yes.
All right. So I'm going to just go ahead and start where Lindsay and Stephanie left off. So, obviously, these are regional findings for the community health needs assessment every 3 years, but each health system, including Sharp, works closely with the hospital association on these results. And there are some regulations, for nonprofit hospitals in particular to conduct their own internal process as well. So Sharp does that, and I'm going to talk a little bit about that. And I just wanted to add that because of some of our communities where there are facilities, we do find in our own data collection that maternal and prenatal care, including high-risk pregnancy, comes up as a priority need, particularly because we have the Mary Birch Women and Newborns Hospital, as well as some robust programming at Chula Vista and Grossmont for women and newborns. So to some degree, we do tailor a bit to our own work, and just jumping into what that means in terms of community benefit. Before I joined the Sharp team, which was in April, some of you may be more familiar with my predecessor, Jillian Warrener. I didn't realize community benefit meant something very specific for hospitals. And so why is it important to talk about community benefit in a certain way if you're a nonprofit hospital, or really any hospital? So for Sharp, it's a part of our mission to conduct community benefit, but what it really means in terms of our planning and reporting is that we are responding directly to what is identified in our community health needs assessments regionally. So another large aspect of what we do in community benefit, besides deploy the programs, is to financially value the commitment. So that's kind of tricky when you're talking about how you interpret the hours that a staff person spends, out in the community on behalf of Sharp, providing a service to a community member. But it is, a requirement, and it's also the right thing to do. So just moving forward, it's pretty basic in terms of what we break down and put in the report. So I won't spend a ton of time going over this, but just to give folks an idea again of what community benefit means when it comes to assessing it. financially and for our stakeholders, at the state and laterally or locally in this community. It's an overview of our plans. It's entity specific to some degree. So, some great efforts at Grossmont may be different than some of the great efforts we hear about from our folks at Coronado or Memorial. But suffice to say, each year we do put out this report, even though every 3 years we do a needs assessment. Every year we put out a community benefit plan, and it adheres to the most recent community health needs assessment results. So our upcoming report will take into account what we just learned from our community through what you just heard about with the hospital association. What counts when we go and we try to determine what it means to provide community benefit as a hospital? There are a number of things that we look at. So, I mean, for example, I'm on the National Alliance of Mental Illness Board of Directors. Mental health is very important to me. It does align with what Sharp wants for, behavioral health advocacy in our community, but it is something I would do independent of my job at Sharp. So it's kind of, questionable whether or not that would apply, but generally it's activity that we conduct on behalf of our organization. It's free. There are services that don't make a profit for our hospital system or our health system. And they, again, address identified community needs. And my team, the community benefit team that does administration, helps the rest of our team sort of figure out how we quantify that. So just a breakdown, just some numbers. It's kind of dry, but just to give everybody an idea, this is somewhat similar across health systems, whether they're required to report on their investment or not. You see that health systems are providing a significant number of dollars in unreimbursed medical care. But what I've highlighted in the brackets are the investments that, in my opinion, most people see. These are the vaccine clinics. These are the internship opportunities, the mentorship opportunities, these opportunities that we're all here to talk about tonight to benefit vulnerable populations, the action that we take in community settings. So about $500 million, I hope I said that right. I'm not always great with numbers, in total community benefit, but you will see there is that slice underneath that is about actually going out into the community. And then there's a portion, obviously, that's of higher cost that relates to our uncompensated care. Just a quick, what does that look like? What does community benefit look like in an organization of 19,000 employees? I live in the purple. Amy lives in that bluish green, and all of you live in the very green. So there is a centralized team at Sharp. And again, this varies across health systems. So I do want to go ahead and point that out. Some people operate in a different structure, but our strategic planning department at Sharp has our community benefit administration team. That's me and a bunch of wonderful, talented individuals that help collect data from all of the programs and services that are provided by case managers, clinical leads, subject matter experts across the system. And so, Amy and myself and some of our team members went through that process of putting that into what are we going to do about this format. It's teams at facilities that understand the populations. It's not our administration. We of course collaborate to get the data. We have partnerships, but it's really all of the people that are working with these populations and have passion and expertise in these fields that orchestrate these plans and lead and implement the activities that we would call community benefit. And we can't do that without our partners. So these plans are executed across San Diego County. If you're a healthcare district, community benefit obviously looks a little different. The Grossmont Healthcare District looks at the needs assessment to administer its grants. A hospital obviously looks at it in terms of what we're doing at our hospitals and our outpatient clinics. And Sharp has a health plan, but again, that of course varies across systems in San Diego County, statewide and nationally. Nationally, this is something that is done across health systems, and requirements vary from state to state, but just a snapshot. Yes, Amy.
Can you help define the difference between a community hospital and a district hospital?
Sure, absolutely. So I'm going to do my best here. So a healthcare district hospital, post World War II, communities weren't incredibly developed, but healthcare needs and services, a demand for them were cropping up. And as, towns were kind of forming post-war. And so what you'll see, well, back in the 50s, a healthcare district was like a water district or any other government entity voted in by the people to establish a service. So basically, a district hospital is a public hospital. A community hospital is a private hospital. It's not necessarily for profit. Obviously, us nonprofit hospitals have to conduct the community benefit, but there is a difference between a private health system and one that's essentially owned by taxpayers, and that's what a healthcare district hospital is. Tri-City, Palomar, they're also district hospitals. It might not seem that way because they operate their hospitals. Sharp Grossmont, for instance, is Grossmont Hospital is a district hospital, but that public entity contracted it out to Sharp. So it gets kind of complex depending on what community you're in, but a district hospital essentially is a public hospital. And so they're not necessarily required in the same way that a community, as you said, or a private hospital would be required to, maintain their nonprofit status. They're public, so they are by design nonprofit in that way. I hope that helps. So here's just a snippet. I think everybody's strategic plans look a little differently, but for Sharp, and I would imagine for many health systems, it's about, creating a plan. So community safety, I think Lindsay touched earlier beautifully on how issues as sensitive as human trafficking and domestic violence are really addressing multiple findings in our needs assessment. It lives in community safety for our planning purposes, but I think we can all appreciate that, economic stability plays into some of our victims' lives and child and youth well-being and so on and so forth. So this is just, again, a snapshot. We don't put anybody's names in here. These are publicly available. Some of you can probably appreciate that Amy is one of the responsible parties on this one. But just to give you guys a taste of how it actually makes it onto paper. And we do this across entities for all of our findings. What does it actually look like in action? Many things. So I mentioned a few a little earlier, but it's everything from being out in the community and doing a clothing drive to the professional development and educational enhancement that our system devises for our own staff to go out and then deploy in the community. Students and interns, yes, you can see all the ways here. Advocating for a cause that is important in a community space where perhaps folks are more knowledgeable than you. You're all more knowledgeable than I am on human trafficking. These all count and these all matter. So these are just a few examples, again, across hospital systems, I would think. We do have all of these information and these materials available online. Sharp.com/community will redirect you to the appropriate page. And I'm happy to answer any questions here or later on. So I appreciate the time.
Thanks, Erica. I wanted to make a comment, and this is not a criticism of you. It's just for the sake of everyone present. When we're talking about people who have experienced human trafficking, we don't use the word victim. We use the word survivor or patient or their name, just because it's more respectful and facilitates. It's a more trauma-informed approach and is more dignified for them. So, and you'd see that like on TV or in a courtroom, but honestly, a courtroom is the only place where it's appropriate. And I don't expect that you or everyone here would know that. I'm just saying that to help everyone to keep that in mind.
Very much appreciate that. I think, without being in this space, I wouldn't know that. And so I appreciate that.
Yeah. And I think that's part of trauma-informed care. And if you use the trauma-informed care continuing ed that Sharp has provided, a lot of that is just reframing things in a patient-positive way, so that we'd reduce stigma and support the patient's dignity and autonomy. So,
Can I also add to that, even with something with regards to being a survivor or victim, I always see victims as someone who has succumbed and has been taken or who has passed. Survivors are those who have survived the trauma. And so therefore that's the delineation between victim and survivor, is that the victim unfortunately did not manage to survive whatever they went through. The survivor did. And that lends an added dignity, I think, or certainly a sense of what they've been through in being a survivor. It adds that weight to it.
sure. And in our welcome packet, we have some really clear-cut guidelines for interacting with people that are lived experience experts, including ask them how they would like to be referred. You know, some people want to just be referred to as their licensure, or they're the CEO of their nonprofit, whatever it is. Just like you would interact with a patient, you want to give the most respectful way to say their name. And then if they correct you and are more comfortable with more familiar names, then that's great. But always erring on the side of the most respect is the best way to go. So I really appreciate the like your presentation, Erica, and just kind of like one of the things as the reason, to be honest, that we've been able to partner with the Hospital Association and Erica and creating a strategic plan at Sharp is because I did report my community benefit hours, which takes a little bit of time and effort, but it supports Sharp and the mission. It also gives the work that we're doing here some visibility, and it helps them to, helps all of the stakeholders to know, you know, what's going on and how can we help. So like on Friday, I'm going to teach a lecture at Point Loma Nazarene to some nursing students, and I'll report that. And that's good for those students to learn how to approach this in a trauma-informed way and in starting their nursing careers. It's also good for Sharp. It's one of those synergistic things that really everybody wins. So please, as you're doing this type of work, report this up through your system with whatever mechanism they give you, because it does make a difference.
Happy to have you as a colleague.
And I feel the same way, Erica. I appreciate your help. I do. Does anyone have any questions, comments for our wonderful speakers tonight?
Amy, this is Tom. Tom Coleman. I know there's another Thomas on. Great. It's really great to hear what's come out of the community health needs assessment. I got a chance just to look. I think it's 222 pages long, so it'll take some time to digest everything. But I think from a public health lens, it's going to be a great document on a lot of different levels. So kudos to Hastic and the team there. Erica, I really appreciate, you know, what you were describing as well. I'm going to ask a pointed question, but you'll understand why it is coming from your background. So I noticed, I don't want to say disproportionate amount, but you know, the preponderance of what was defined as community benefit was uncompensated care. And that a lot of times is historically what is used. And I'm not being critical of that because, you know, people that don't have a medical home, you know, they'll find care somewhere. And I know that you're still, you know, relatively new in your job, but coming from a very strong public health background, do you envision that for Sharp, at least, that lens might change a little bit more toward public health, more population health based things from a public health lens than necessarily the uncompensated care part?
I think Thank you, Dr. Coleman. And I think that there is an acknowledgement of that disproportionality across our system, you know, and knowing that we can't necessarily reduce what we're providing in that uncompensated care category, how can we focus on what we can do to enhance what we're providing in the other categories? So with my background, I'm excited to dig in.
Yeah, I was going to also add that my experience is from Denmark. Because I have cousins who are nurses there and who work on projects as well. It's nice to see. I think it's very encouraging to see what you're doing in terms of bringing the community in and connected to the hospitals, not something separate, but something with that it is all encompassing. Because I think it's very important to get that kind of support more and more. And you know, it's a different system in Europe, but I mean, especially in Denmark. But I have a cousin who's a nurse, and she's faculty, and she works on projects for drug addiction and for these various things. And there doesn't seem to be as much of that here. And this is so encouraging. What I'm seeing with regards to human trafficking, etc., and what Amy has done, what all of you have done, in terms of reaching out, really, and recognizing that the situation exists. And I just say kudos to you as well for what you're doing. I mean, honestly, it's much needed, probably long overdue, but you're doing it. And again, thank you.
Thanks, Lisa. And like, we've already partnered on one continuing ed event where we did the non-fatal strangulation continuing ed last month. Thank you again for that. And I wanted to point out too that trauma-informed care is, like, there's a Journal of the American Medical Association article that talks about it is in the terms of universal precautions, just like you would put gloves on if you're going to handle bodily fluids. Like psychological trauma is not rare. We all have experienced this. And if we can adopt trauma-informed care practices for all of our patient encounters, it doesn't matter what their background is, we're going to support that patient in the best possible way. And so please leverage what they've produced to implement trauma-informed care practices and to update the way that we interact with patients, regardless of where you're working at. And one thing that I've noticed in the needs assessment also is all of these social determinants of health, whether it's like we've had a lot of people exit the workforce. If you're mentoring young people and preparing them for a health career, you're giving them a real opportunity that maybe they wouldn't have. And that can prevent them getting sucked into human trafficking and other things that are unsavory. So that is also helpful. Like if you're addressing food insecurity or housing insecurity, or like all of these other things that funnel into human trafficking, all of it makes a difference. So if you have other opportunities or places where you want to spend your energy, don't feel bad about that. All of it makes a difference. We've had I could talk all night, but I just wanted to give all of you some time and space to make comments or ask questions since we have these presenters here tonight. I know there's some people that weren't able to attend because of other commitments and time constraints. Yeah, that's a great idea, Kat. I'm going to stop recording.